Okay, assalamu alaikum everyone. My name is Maryam Altayeb. For those of you who don't know me, I'm currently a medical intern. And today I'm going to be giving you guys a reproductive physiology review for your under repro course. Now, like I mentioned, to those of you who just joined, I'm going to try and touch on important questions and important key topics. I know I can't give you everything within 2 hours, but inshallah, you're going to find it beneficial. And I hope this clears up any questions you guys have. So the way I'm going to go about this, of course, you're free to ask questions at any time during the chat. I'm going to be explaining basic concepts in the beginning, and then after that, we're going to go into questions, and I divided this into each different system. So female reproductive, pregnancy, male reproductive, and sexual development and differentiation, all right? So this is going to be a question and answer session with discussion as well. So please feel free to ask anytime. So with all that being said, let's start with the female reproductive system. So as females, we are born with approximately 200 million follicles at birth. And these are what we're calling primordial follicles. So these are our follicular cells. Oh, sorry. And you have your primary oocyte. Our primary oocytes have 46 chromosomes. Now, why is this important? Because when you're going to pass off your genetic material to your offspring, you're going to pass 23 from your mother and 23 from your father. And those are what we call gametes. And for our gametes to be complete, we need to complete meiosis 1 and meiosis 2. So in our primordial follicles, we have 46 chromosomes, and then after meiosis 1, that turns into 23 chromosomes. And so this doesn't happen with every single one of our 2 million follicles. In a lifetime, this actually happens with about 400. And what happens eventually is there's different stages of development. So the first stage is from infancy to puberty, where we have these primordial follicles, okay, with follicular cells, and they turn into our primary follicles with granulosa cells. And we're going to talk about the cell types in a second, okay? And so our primary oocyte stays in the prophase of meiosis 1, okay? And so all throughout childhood, that's where they're stuck. Why is that the case? Well, afterwards, only a few primary follicles. Remember, I told you out of those like 4 million, we only have maybe 400 that undergo this process. So a few primary follicles enter each menstrual cycle. And so these primary follicles turn into secondary follicles that turn into tertiary or Graafian follicles. And so remember what we said, our primary oocyte is stuck at prophase of meiosis 1. What happens is you get more granulosa cells and more theca cells growing around. And the important part about this is that this is what produces our hormones that are responsible for the changes in the menstrual cycle. So you have your granulosa cells and your theca cells, which are able to convert a hormone called androstenedione into estradiol and progesterone. And so important thing for you guys to keep in mind is our theca cells have our androstenedione. However, our granulosa cells have the aromatase enzyme responsible for this conversion. So these two work together, all right? And so our granulosa cells are what you guys can see here inside, okay? And our theca cells are on the outside. So the actual production of estradiol is by the theca cells, not by our granulosa cells. And so these follicles are going to keep on growing until we have something called a tertiary or a Graafian follicle. And what changes here is, again, we still have our primary oocyte that's stuck, but it starts to form an antrum, this fluid-filled space. This is a nourishing fluid that's created by our granulosa cells. So these cells here, see how you have starting of an antrum to form? This is when it forms and it secretes more nourishing fluid. All right. And so this second stage takes like about 70 to 85 days. So it takes a while, definitely. And what happens is you have something called the menstrual cycle. Now, this whole process of turning into a tertiary follicle doesn't happen with every single one of our follicles, only the most dominant one. And that dominant follicle causes an oocyte to be released, okay, due to the LH surge. I'm going to talk more about the menstrual cycle in a lot of detail, so don't you worry. But what's important for you guys to know is that this happens in two phases. Our follicular phase happens during the first 2 weeks, and our luteal phase happens in the last 2 weeks. And ovulation happens at day 14. And so ovulation is actually the day when this oocyte is released because of an increase in two hormones, LH and FSH. All right, and we're going to go into more detail with that in a second. So we said that this whole process of menstruation starts, but what causes it to start? And this is important for both male and female reproduction, but we're going to talk about the female reproductive system right now. So you have something called your hypothalamus, right? Which is in your brain, your hypothalamus and your pituitary. And this forms an axis, meaning that a hormone from here is going down to the pituitary, causing other hormones to be released, and so on and so forth. So this GnRH, or gonadotropin releasing hormone, before puberty is only secreted in small continuous amounts. And during puberty, remember we said the follicles are not really maturing, they're not developing, nothing is going on. That's because your pituitary is not really detecting the low levels of GnRH as a stimulant. It's just تقريبا constantly there, or almost constantly there. But the important thing that happens with puberty is instead of being at a constant low continuous level, instead it's secreted in pulses. So it goes up and down and up and down and so on and so forth. And when it's released in this pulsatile fashion, that's what causes our pituitary to release two hormones that are very important, and we're going to be talking about a lot today, okay? You have FSH, or follicle stimulating hormone, which, as you would think, stimulates the follicles to grow, and luteinizing hormone. So our FSH is going to bind to our granulosa cells to make aromatase and estrogen, okay? And our theca cells, remember, those produce the androstenedione that then go to our granulosa cells to make our estrogen, okay? Because our granulosa cells have our aromatase, but our theca cells don't. So that's just an important differentiation to keep in mind. And so when we make these estrogen and also progesterone, these are the two key hormones in the female reproductive cycle. What happens is that this is going to go back to our pituitary and tell it, hey, we don't need to secrete as much FSH and LH. So this is what we call feedback loop. So it's either going to be positive feedback, meaning it's going to cause it to secrete more, or negative feedback. But the important thing here is that this loop is going to cause our follicle to develop. All right. And so this is another thing, or this is essentially how it looks like. Okay. So let's start with our follicular phase. So let's say menstruation happened. Now we enter our follicular phase. A few Graafian follicles enter the third stage of development. Okay, and then we have, remember, the pituitary is now secreting something called FSH, or follicle stimulating hormone. From the name alone, it's going to stimulate the follicles to grow, right? So FSH, remember, makes follicles grow, and it causes our granulosa cells, which are the ones on the inside, to produce more estrogen. Because remember, our granulosa cells have our aromatase enzyme, and also secretes something called activin. So from the name alone, active, to go. Activin is something that's going to help you do something. And so activin stimulates FSH production and binds FSH receptors in the granulosa cells. So this causes these cells to produce even more aromatase and even more estrogen. All right, so this is what our activin is doing. And this helps with our initial phase. And so remember, again, we're just talking about a few follicles. And what happens because of the release of activin, a small increase in FSH leads to a big increase in estrogen. Now, when you have this big surge of estrogen, then you're going to have your negative feedback. That's going to tell the pituitary gland, okay, we don't need that much FSH anymore, and only the strongest follicle is going to be stimulated. That's what we call our dominant follicle. So you have all of these tertiary follicles growing, but eventually only the strongest one is going to remain, okay? So the dominant follicle secretes even more estrogen, and now the pituitary is more responsive to GnRH. When estrogen reaches a specific amount, that leads to positive feedback. So I know it's a bit confusing, so I'm going to try to clear it up for you guys. Essentially, you're going to have initially an increase in LH and FSH. That's going to cause all of these follicles to grow. All right. And our granulosa cells to produce more estrogen. When they produce a very high amount of estrogen, what's going to end up happening, as per here? Okay, you're going to produce, all right, so this is going to be easier for you guys to see. The picture is the same. So it's going to produce a high amount of estrogen. When you have a lot of estrogen, that's going to tell your FSH to calm down, okay? Your pituitary to stop secreting FSH. As a result, only one follicle, which is the strongest follicle, is actually going to continue in its development, all right? So what happens then is when estrogen reaches very high amounts, that's going to create positive feedback. And the only thing that's going to remain growing is our dominant follicle, the strongest one. And when this happens, when you have this big surge of FSH and LH, our primary oocyte is going to be converted to our secondary oocyte. So remember how it was stuck in prophase of meiosis 1? This LH surge is responsible for it to continue its development. Okay, so this is what happens. This is what we call ovulation. So you spend the entire follicular phase causing everything to grow. You're choosing your dominant follicle. Once your dominant follicle secretes more estrogen, it's going to cause this peak of FSH and LH. And then the follicle is going to rupture basically. And then this is going to be released as a secondary oocyte into the fallopian tube, ready for fertilization. And so initially, we remember our primary follicle stops in meiosis of a prophase of meiosis 1. And our secondary oocyte now, thanks to the LH surge, stops in metaphase of meiosis 2. All right, now we enter our luteal phase. Okay, and so why do we call it the luteal phase? Well, because you have something called your corpus luteum. So you have your granulosa cells and your theca cells that now here, this is where ovulation occurred and this exploded essentially. This is going to turn into the corpus luteum, and your granulosa cells are going to secrete 17-beta estradiol, and your theca cells are going to secrete androstenedione. So remember, these two cells work together. Your androstenedione is going to be converted into estradiol by the aromatase in the granulosa cells. This also leads to a decrease of LH and an increase of this enzyme, so P450SCC. What this enzyme does is it helps convert our cholesterol into progesterone. So think of it as the primary hormone that we're looking at in the follicular in the early phase is our estrogen, our estradiol. Now we're switching from estrogen to progesterone. This becomes the dominant hormone. Why? Because of this luteinization, the surge of LH causes it to increase this enzyme. Okay, it's going to increase the P450-SSC. That's going to cause us to convert our cholesterol to pregnenolone and then progesterone. Okay, and you have a hormone that we produce. Remember, in the follicular phase, we talked about activin that activates. Now, you have a hormone produced called inhibin, which inhibits. So after this boost of FSH and LH, inhibin is going to cause it to be decreased now. Okay, and then basically we graph this all out. So the reason we did all of this is so that our secondary oocyte can get fertilized. But what if fertilization doesn't happen? Well, what happens is your corpus luteum, which is producing our estradiol and our progesterone, dies. It becomes something called the corpus albicans. And when you have a drop in all of your hormones, in your progesterone and in your estrogen, what ends up happening is the uterus lining sheds, which is what we call menstruation. Okay, here essentially. So you have all of this was basically to prepare a baby for being born. But if that doesn't happen, this inner lining dies off by apoptosis and sheds. So we're follicular phase where we try to thicken the endometrium. the luteal phase, where your spiral arteries formed, and these are keywords for you guys to remember in terms of questions. If no fertilization happens, these spiral arteries collapse, the superficial layers of the inner lining dies, and then that causes menstrual bleeding. And you also have smooth muscle contractions, which is what causes menstrual pain. So essentially what's important is if fertilization does occur, the corpus luteum continues to make progesterone until the placenta forms. And this is because of a hormone called beta-HCG, okay? Or human chorionic gonadotropin that's released when the cells implant, but we'll talk about that with the pregnancy a bit more. Okay, so this is basically what everything looks like, what we talked about. So you have your tertiary follicles. You get a selection of your dominant follicle. And remember, this one continues to secrete estradiol, which you can see here, until it gets above a level. And then that causes your pituitary to start to secrete a lot more LH and FSH. This LH surge is what causes your ovulation to happen. Okay. And then this travels through your fallopian tubes, okay, waiting to be fertilized. If that doesn't happen, you get your corpus albicans from your grafting follicle, your granulosa and theca cells, and menstruation happens. If it does happen, your corpus luteum is maintained by beta-HCG, and then pregnancy continues. And so this is what it looks like in terms of the actual endometrium. If fertilization doesn't happen, you get shedding of the uterine lining, and this is the beginning of our follicular phase. This is our menstrual cycle. Then you get your proliferative phase when you select the follicle, and this is basically mediated by estrogen, or estradiol more specifically. Then, if that continues, you have your secretory phase after ovulation, and this is mainly mediated by progesterone, and you can see that here, produced by our corpus luteum. Okay, so now that just everything is generally reviewed and hopefully much clearer for you guys. Let's take the first question. Okay. So guys, please feel free to answer. I'm going to read it out with you and then we can discuss it together. So an investigator is studying the menstrual cycle in premenopausal female volunteers with normal ovarian function. Endometrial biopsy specimens are taken from each volunteer every 6 days for a month. And this is the important part. And capillary lumen area and endometrial layer thickness are measured. Microscopic examination of one such specimen shows condensed endometrial cells with deeply eosinophilic cytoplasm and basophilic fragmented Schrecken nuclei. These types of cells are most likely to be seen in which of the following points of the menstrual cycle? So take your time, guys, like within 1 minute. Feel free to answer, think about it, and we'll discuss it in a second. Okay, do you guys want to write your answers in the chat so we can discuss? It's okay, take your time. And guys, please feel free to share your answers in the chat with everyone. And again, we're here to learn. No answer is a stupid answer. We're here to learn. Okay. So the answer to this question, you didn't see the second answer. All right. The answer to this question is F. to know here, and this applies for all of you're going to think about in the future. Condensed endometrial cells, deeply eosinophilic cytoplasm, there's shrunken, fragmented nuclei. This is describing apoptosis. So apoptosis is basically a programmed cell death, or a way these cells die off. And so this nuclear shrinkage is what we call pycnosis, and fragmentation is karyohexis. And so this is, again, features of apoptosis. When does apoptosis happen? When you're getting ready to shed your uterine lining. This is usually day 28, and this is when menstruation begins. Okay. So out of all of these options, this is the one that is correct. So endometrial cells undergo apoptosis just before being sloughed off. Okay, so this is the first question. You did not see the answer to that, I'm hoping. Okay. Second question that is also similar. In an adult woman with a normal menstrual cycle, estrogen levels in the blood are continually increasing for 6 to 8 days after menstruation. What is the source of estrogen in this case? So think about what we talked about in the first phase. We're entering the follicular phase. In the follicular phase, you have an increase in estrogen. Where is that coming from? What do you guys think? Okay. All right. Keep them coming. Yes, you guys are correct. Perfect. Mumtaz. So in this case, our answer is B. And remember what happens in the follicular phase after menstruation starts, you're going to have development of the new follicles, right? And then from those, they're going to develop into Graafian follicles or tertiary follicles. And then one dominant follicle is going to remain. That's all happening within the menstrual cycle, the follicular phase, the beginning part, because you need to choose one dominant follicle in order for for ovulation to happen, and then the luteal phase to occur. So our developing follicles are producing our estrogen levels. Why is estrogen being produced? Remember, your pituitary gland is going to have an increase in FSH and LH, but more FSH in this case. And that's going to go stimulate our granulosa cells and our theca cells, where our theca cells are going to produce our androstenedione, remember, and then by the aromatase enzyme in the granulosa cells, that's going to become estradiol. So that's the key process here. So that's what's causing our estrogen to increase in the first 6 to 8 days after menstruation. The corpus luteum is more responsible for producing progesterone in the luteal phase. Our endometrium doesn't really produce anything. Our ovarian stromal cells are actually going to help produce the nourishing fluid. All right. And pituitary gonadotropes are producing the hormone responsible for this, but they're not this direct source of estrogen. Okay. So next question, which of the following hormones is responsible for reinitiating meiosis in the primary oocyte? A, LH, B, FSH, C, TSH, or D, ACTH? What do you guys think? Mm-hmm. Mm-hmm. Yep, you guys are right. So LH is the primary hormone responsible for, remember, it's causing ovulation, and after that, it's leading to reinitiating meiosis in the primary oocyte. So in our primary follicle, okay, our primary oocyte, it's going to be stuck at prophase of meiosis 1. Then it's going to move to, do you guys remember the where it gets stuck after ovulation happens? Metaphase 2 of, yes, okay, so metaphase of meiosis 2. So first it's in prophase of meiosis 1, then LH surge happens. LH helps with ovulation process. And then once that is released, it's going to be in the metaphase of meiosis 2. And remember, our oocyte only ever completes meiosis after fertilization. It's not like the male, spermatocytes. those complete and those are like ready to go. But we, like as females, need to take more time for it to happen. Okay. Thecal cells in the follicle are not able to produce what sex steroid? What do you guys think the answer is? A. Okay. Anyone else has any other answers? Okay, you guys are correct. The answer is A. Which enzyme is not present in thecal cells? Why can't we produce estradiol? Aromatase. Perfect. So our aromatase enzyme is present only in our granulosa cells, and for that reason, we're not able to produce estradiol, only androstenediol. Okay, so that's important, and that came up in a lot of previous questions. So this is just an overview so you guys can see. So these hormones generally come from cholesterol. That's our main part. And the main source of estradiol is the ovaries, but there's a very small amount of these sex steroids also produced from your forgot the name. We'll get to it in a second. Your suprarenal gland, your adrenal gland. So what happens is, I hope you guys can't hear my family moving furniture at the most inconvenient time. But so what happens is your cholesterol turns into pregnenolone, and your pregnenolone turns into progesterone in your theca cells. Remember, this really, really happens, or we have the most amount of progesterone in the luteal phase. In our follicular phase, that pregnenolone is turned into intermediates like 17-hydroxypregnenolone, DHEA, again by this 3-beta hydroxysteroid dehydrogenase. This is a very useful enzyme, as you can see. And then it's converted into androstenediol. Okay. And then that is converted into 17-beta estradiol in our granulosa cells by the aromatase enzyme. And this is stimulated by FSH. That's why it's important that we have those levels of FSH and LH high in the early phases of the menstrual cycle, because it causes these enzymes and causes this increase in 17-beta estradiol. Once that happens, it's released into the blood. You have it bound by sex hormone binding globulins and some free amount as well. And it's important to go to blood vessels, bones, and it's especially important for bone development. That's why a lot of people post-menopause get diseases like osteoporosis or hashashat al-'idham, or just the weakness in the bones, and also stimulates the uterus and vagina and whatnot. So for this reason, high levels of estrogen can actually cause blood clots. It's one of the things it can do. And that's one of the side effects of oral contraceptives and hormone replacement therapy and other ones as well. And so that is for estradiol. What about progesterone? So remember, when you see the decrease in LH, what happens after the LH surge? What happens is this is detected by your cells, specifically more by your theca cells, and what happens is it increases P450 SSC, and so this causes increased levels of progesterone to be produced, and progesterone is transported by transport, and albumin goes to target tissue. So this is more so in the luteal phase, and you have more estradiol in your follicular phase. So both of them are present at each phase, but this is just present in a greater amount now in the later phase, okay? So this is our next question. I know some of these questions are a bit long, but you never know what they can get you in your exam. So I just want to make sure you guys are clear on. A 43-year-old woman, gravid 2, pair 2, comes to the physician because of a 6-month history of heavy, irregular menstrual bleeding. Pelvic examination shows blood and clots in the posterior fornix and normal appearing internal and external genitalia. An endometrial biopsy shows straight, uniform tubular cells lined with tall pseudostratified columnar epithelial cells with high mitotic activity embedded in an edematous stroma. increase of which of the following is directly responsible for the histologic appearance of the biopsy specimen? Okay. A, luteinizing hormone, B, corpus luteum, C, 5-alpha reductase, D, theca externicels, or E, aromatase. So to give you guys a hint of this specific biopsy presentation, this is present in the proliferative phase. And so remember, in the proliferative phase, the key hormone that we're talking about is estradiol. That's in our follicular phase. So that's just another way of me asking this question would be, what is responsible for the increase in estradiol? Exactly. So in this case, the answer, you guys are correct, would be E. Okay. So again, patient endometrial biopsy is showing that there is straight uniform tubular glands. If they mention something about spiral arteries, then you would think more so about your luteal phase. Then I could tell you, okay, you can have corpus luteum as the answer, for example. But in this case, there's a very high mitotic activity. That tells you that it's proliferating, even if you weren't 100% sure of the specific answer. Just think high mitotic activity. That means my inner lining is proliferating, so I must be in the proliferative phase. They would describe more of an edematous stroma, spiral arteries, if you're talking about the luteal phase. And so endometrial proliferation in the follicular phase and in the proliferative subphase is due to high levels of estradiol, which you guys remember is produced by our granulosa cells because they have aromatase of the different developing follicles, okay? Is that clear for everyone? Do you guys have any questions about this? So it's important for you guys to know the histologic appearance because they can definitely ask you about it. Okay, perfect. So next question. Home use ovulation predictor kits measure 2 urinary hormones and display a smiley face when ovulation is predicted to occur. In addition to luteinizing hormone, which of the following hormones is likely measured as a part of the kit? What do you guys think? Repeat the last one. Okay, I'll repeat the last question in a second. Let's just solve this one first. All right. Any other thoughts? Okay. All right. So the answer to this question is actually B, estradiol. I know it's a bit confusing because home predictor kits, we usually immediately jump to pregnancy test, but this isn't a pregnancy test. This is an ovulation test. So remember when we look at our graph, during ovulation, what happens? You have a high level of estradiol that's released by our primary follicle that causes our LH surge, and then everything starts to fall. So in ovulation, you actually have very high levels of estradiol and high levels of LH and FSH as well, but it's usually estradiol is measured. And so this is what the actual test looks like. You can see the smiley face here associated. Sorry, where did my laser pointer go? The smiley face here associated with the positive test. So this is what the digital ovulation test does. It actually tests estradiol. Beta HCG is actually tested to detect pregnancy a few weeks after. Okay, so I'm just going to repeat the last question because someone had an inquiry about it. All right, so the key thing here is they might get you guys questions where they tell you, oh, this was the biopsy result. They can ask it in 2 ways. They can either ask you what phase of the menstrual cycle is this person in, or they can ask you indirectly and talk about the hormones responsible for this phase of the menstrual cycle. So basically what happens, you have menstruation or a woman's menstrual period. After that, the endometrium is going to start to grow again. And that's because you have higher levels of your estradiol being produced. And so that's what's causing very high mitotic activity, proliferation of your endometrial stroma. And so what they're asking in this question is, one, they want you to know which phase is this biopsy in. And so when they tell you there's high mitotic activity, uniform tubular glands, these are the features you guys need to know are part of the proliferative phase, or the follicular phase of your menstrual cycle. So this is the follicular phase. What hormone is important in my follicular phase? Estradiol. What is the hormone or what is the enzyme responsible for making my estradiol? Aromatase. So that's basically a long-winded way of asking the question. But we know steps 1, 2, 3. So our follicular phase, you have your proliferative part where the endometrium is growing again after menstruation. That happens due to high levels of estradiol. And why do we have high levels of estradiol? Because increased activity of our aromatase enzyme. All right, I hope that clears this up. All right, is that clear now? Okay, I'm not a big fan of this laser pointer. And for this question, this is not a pregnancy test. This is an ovulation test. It tests whether or not ovulation happened to see if a woman is in her fertility window or not. They're not usually as reliable or as widely used, but they can ask you this question. I think it came in a previous one as well. Okay, so next question. When do progesterone levels rise to their highest point during the female hormonal cycle? A, between ovulation and the beginning of menstruation. B, immediately before ovulation. C, when the blood concentration of LH is at its highest point. D, when 12 primary follicles are developing to the antral stage. What do you guys think is the answer here? What else? Any more ideas? Mid-luteal. Perfect. Okay. So the luteal phase is between what and what? Exactly. So another way of saying that, luteal phase is between ovulation, right, which happens at day 14, and the beginning of menstruation, which happens at day 28. So that's why A is the answer here. That's when progesterone is at its highest point because it's produced by the corpus luteum. So we know the corpus luteum is the only source of progesterone production. You have very minimal amounts of it in the early phase of the menstrual cycle. And so immediately before ovulation, this is wrong. Why? Because the LH surge is what causes ovulation to occur, right? And then after that, you develop your corpus luteum and start to produce progesterone. So that's not the correct answer here. When blood concentration of LH is at its highest point, same concept. This is when you have the LH surge. At this point specifically, that's what causes your follicle to rupture, but you haven't formed the corpus albicans just yet. Your corpus luteum, sorry, just yet. When 12 primary follicles are developing to the antral stage, here they're describing the follicular phase. That's not what's happening here. So between ovulation and the beginning of menstruation, that's the correct answer. Okay. So this is again, here, this is when you have your increase in estradiol and your LH. This is your LH surge that causes ovulation to occur. Then you develop your corpus luteum, which is what produces your highest level of progesterone, okay? If fertilization occurs here, amazing. The beta HCG from the cells that are going to be, we'll talk about that in a second, your syncytial trophoblasts, after it implants into the wall of the uterus, that's going to maintain your corpus luteum, meaning it's going to continue to produce progesterone until your placenta is formed, and then that takes over. If not, if fertilization doesn't happen, then your hormone levels are going to fall. Your corpus luteum becomes your corpus albicans, and then this is when menstruation happens at day 28. So this is just a very good view for you guys to know. It is very important for you guys to know the levels of these hormones, what each peak looks like, which one is estradiol versus LH versus progesterone. Very important for you guys to know. This is the last question we have for menstrual physiology and all of these things. Do you have any specific questions or anything that's still unclear? It's, I think, the heaviest part of the review session. All clear? Okay. Let me know if you guys have anything, even as we continue along. All right. So now I have a few topics for you guys, a few important concepts for pregnancy. Okay. Um, so this I hope will clear up the topic you had before. Um, for your question, the biopsy of an endometrium, can you review it again? Okay, I'll try to. This is more of a histology topic for you guys, but I'll try to go through it so you know. If I take a biopsy here, okay, this is the menstrual phase. Menstruation is happening, meaning your follicle, okay, or your oocyte did not get fertilized. So your inner endometrial lining is going to undergo apoptosis and die and slough off, okay? So if I take a biopsy here, what am I going to see? I'm going to see cells that are very shrunken, that are very small, have very darkly pigmented nuclei. All of these features are features of apoptosis, okay? Then after this, what happens? You see your increase, the purple line here, this increase in estradiol from these follicles, these growing follicles, that causes proliferation. So here, if I take a biopsy, I'm going to see that there's very high mitotic activity, straight tubular glands. This is because you have estradiol. Okay, so this is the proliferative phase. And so all of this is the follicular phase. That's what we're talking about here. Then after the LH surge happens, something interesting happens. I have increased levels of progesterone. So you can see here on the endometrial biopsy how it gets thicker. Think of it as like a cushion welcoming the new baby for implantation. So it's called the secretory phase. So you get a lot of edematous stroma. You have your spiral arteries. That's what progesterone is responsible for. Think of it as creating a cushion for the baby to be comfortable throughout the pregnancy. And so that's what happens in the secretory phase. So the key thing for you guys to know is what are the different histologic findings here and here and here, and how that corresponds to different hormone levels in the menstrual cycle. So basically, if you guys have this figure in front of you clear and memorized, it's going to make your life a lot easier. But that's the key thing. Here you have apoptotic features. Here you have high mitotic activity and proliferation. Here you have very edematous stroma, spiral arteries, basically getting ready for implantation. If that doesn't happen, then it's going to shed again and you're going to start the menstrual phase all over again. Does that answer your question? Is that clear for everyone? Okay, amazing. All right, so let's get back to this question. A 26-year-old woman comes to the emergency department because of a 3-day history of nausea and vomiting. Her last menstrual period was 9 weeks ago. A urine pregnancy test is positive. Ultrasound shows intrauterine pregnancy consistent in size with a 7-week gestation. The hormone that was measured in this patient's urine to detect the pregnancy is also responsible for which of the following processes? Okay, so this hopefully clears up the question you guys had earlier, which is now we're talking about a pregnancy test. And like you guys correctly mentioned before, pregnancy test, what hormone are we detecting? Let me know in the chat. HCG, amazing. So this is just a very, very long way of me asking, what does HCG do? Who can tell me what HCG does? Or, well, that would be the answer to this question. HCG maintains the corpus luteum. So this is what a urine pregnancy test looks like. This is what most people know, what most people use. If we're being very, very clinically specific, we can also measure HCG in the blood, but this is what they're talking about here. So HCG, or human chorionic gonadotropin, is a dimer, meaning it has 2 subunits, an alpha subunit and a beta subunit. Alpha subunit is like FSH, okay? And luteinizing hormone and thyroid stimulating hormone. And the beta subunit is unique to HCG. So what we're actually detecting is the beta subunit of HCG. Why? Because if I'm detecting the alpha, it's the same as LH, FSH, TSH, which is not what I want, okay? So The pregnancy test is detecting this beta unit, and levels of HCG peak in the first trimester of pregnancy. So this is basically the purpose of our HCG. It maintains our corpus luteum to continue to produce progesterone. Because if that doesn't happen, what's going to go on? Our progesterone is going to fall, and then we're going to have a start of menstruation. If I have a baby, I don't want to shed my uterine lining. I want to maintain it. That's why progesterone is important here. Okay. Yeah, so is that clear for everyone? So this is the difference. If I'm talking about an ovulation test, I'm detecting mostly LH, that's the most important, maybe estradiol. If I'm talking about a pregnancy test, I'm detecting beta HCG. What does beta HCG do? It's going to maintain the corpus luteum so that my corpus luteum produces progesterone. Okay, is that clear for everyone? Yes, okay, perfect. On the same note, we're talking about beta HCG, right? And remember, I say beta HCG because in pregnancy we detect the beta subunit. So HCG is a biomarker that can be used to determine presence or absence of pregnancy. Which of the following best describes the main source of HCG during the initial 2 weeks of pregnancy? A. Corpus luteum, B. Hypothalamus, C. Primordial follicles, D. Corpus albicans, or A. Syncytial trophoblasts. Yep, okay, you guys got it immediately. The answer is E. Syncytial trophoblasts. So what happens is after fertilization, you're going to have your zygote. It's going to implant inside the wall of the uterus. And when it implants inside the wall of the uterus, what's going to happen is you have your cytotrophoblasts, which form your actual fetus, and your syncytial trophoblasts, which are like finger-like projections that go into the endometrium, and they're going to release beta HCG to maintain our corpus luteum. Okay, so these cells release our HCG to prevent our corpus luteum from dying and degenerating into the corpus albicans. Because if it does die, what happens? Corpus albicans is old and dead and shriveled up. No more progesterone, menstruation happens. Okay, so they can ask this question for you guys in either this type of way or this type of way, but it's the same kind of concept. Syncytial trophoblasts, HCG, maintain our corpus luteum. And here they're asking in the initial 2 weeks of pregnancy. After that, basically, so after our initial 2 weeks of pregnancy, it's mainly going to be produced by the placenta. All right? Placenta, perfect, exactly. Okay, so now that's within the initiation of pregnancy. What about labor? That's what we're going to talk about now. So which of the following could inhibit the initiation of labor? A, administration of an antagonists to the actions of progesterone. B, administration of LH. C, administration of prostaglandin E2 antagonist. D, mechanically dilating and stimulating the cervix. Or C, administration of oxytocin. All right. So the answer here is administration of prostaglandin E2 antagonist. Let's look at exactly what the question is asking. Which of the following would inhibit the initiation of labor? Meaning, what can stop labor from happening? In order to know that, we need to know what makes labor happen in the first place. So prostaglandin E2, okay, helps. There's different stages of labor. Okay, so initially when labor starts, you need to make sure that the baby has an opening to go through in the first place, right? So what happens is you have increased production of prostaglandins. For example, we can do this in medication form, like misoprostol, okay? And what happens is that causes the cervix to ripen and flatten and literally open up, okay? Open up so that the baby has a space to go through. That's what we call cervical dilation and effacement. Okay, but just think of it. We need this to kind of let everything soften and open up. Okay, and then after that, once you have opening up of the cervix, your body sends a signal of oxytocin. Okay, oxytocin is a hormone. And what that does is it causes contraction of your endometrium. So the muscles in your uterus contract, or your myometrium, you contract, and then that leads to expulsion of the baby, and then alhamdulillah brought life into the world. So if I want to stop this dilation and effacement and the initial process that starts labor from happening, I need to give something that stops my prostaglandin E2. And so that's why this is the answer here. Administration of an antagonist, meaning something that works against the effects of prostaglandin E2. Okay. Here, for example, mechanically dilating and stimulating the cervix, this is just going to kickstart the process. So this would actually help to initiate labor. Okay, administration of oxytocin that causes my myometrium to contract. So again, this is going to help labor progress. So if I'm asking you what could inhibit the initiation of labor, then my answer is prostaglandin E2 antagonist, something that works against it. If I'm telling you what happens when, or what can help the progression of labor, then I can actually give a prostaglandin like they insert it behind the cervix, and that leads to cervical ripening. And if that doesn't work, then you can mechanically dilate and stimulate. And then if you need augmentation of the contractions or helping with the contractions in labor, you can administer oxytocin. Okay, but so the key concept here is prostaglandin E2 is essential for the starting of labor or the initiation of the process of labor. And if you stop that from happening, you can stop labor from happening. Okay. So these are the main hormonal changes that you will see throughout pregnancy. So remember, initially we have HCG that's going to be secreted by our syncytial trophoblasts, and then that leads to the continuous secretion of progesterone and whatnot by the corpus luteum, and estrogen. So these two are essential to maintain pregnancy and responsible for the physiologic changes that you see. You have other hormones that are important as well, such as prolactin. And prolactin is important to develop the breast tissue so that after the baby is delivered, once oxytocin is released, you can have letdown of milk. And so these are just key hormones. But one thing I want you guys to keep in mind regarding HCG is you see how it's super, super important in the initial phase. Here, when you have your corpus luteum and then the development of the placenta within like the first 14 weeks of gestation, and then it falls, and all of these hormones are allowed to be produced independently. Okay, so just this is what you guys should keep in mind. For the physiologic changes in pregnancy, I know there's a lot of them, but these are the key things you guys should know. So you have an increase in your blood volume, but your plasma is more than your red blood cells, so you get a dilutional anemia. You get increased heart rate, increased cardiac output. Think of it, there's another human being that you need to supply to. So if that's the case, everything in your body kind of needs to go into overdrive. So you have more blood, you have a stronger heart to give out that blood. This decreased systemic vascular resistance that basically allows this blood to more easily reach your developing fetus. Increased central respiratory drive, so increased ventilation, increased breathing, that leads to more oxygen in the blood. Increased blood flow to your kidneys, more urine output, as well as compression of the bladder by your uterus, which is why you see pregnant women going to the bathroom all the time. And importantly, hematologic changes, so increased prothrombotic coagulation factors. So what that means is they're more prone to coagulate, they're more prone to develop clots in their blood. That's why it's very important for us to look for signs of deep vein thrombosis or DVT in pregnancy. And so this is just a general thing you guys can review, but just remember, in pregnancy, you're increasing everything in order to make sure to supply your fetus well. When does the beta HCG decrease later in pregnancy? So as you can see here, between weeks 14 to 21. So that's give or take between the first and like in the second trimester. But what's more important for you guys to understand than when it decreases specifically is when the beta HCG is initially produced by your syncytial trophoblasts, and why it's important. It maintains your corpus luteum. Why? Because you need it to produce progesterone. So at this point, our placenta is independently producing the progesterone. That's why it drops. Okay, and so this is just for you guys to review the physiologic changes in pregnancy. Any questions you guys have about pregnancy or anything you're confused by? Everyone all good? Are you guys tired? Do you want to take a break or do you want to continue? We have two sections left. There's male reproductive system, which is hopefully not too long, and sexual differentiation and development. All good? Okay. All right. Okay. Okay, so Bismillah, now we're going to start with the male reproductive system. So we have our external organs and our internal organs. Our external organs are mainly the penis and the scrotum, which inside it contain testes. And you can see the testes and the different parts. Then you have your internal organs. There's a system of ducts and a system of accessory sex glands. So your duct is basically where your sperm are made here. We're going to talk about the way sperm is made in a moment. And then it's going to essentially go through all of this duct system, these tubes, all the way here. And then you have your accessory sex glands, which, for example, your prostate, these are specific glands, whatnot. And so these help supply different parts or different components to the sperm, and then ejaculation happens, and then male and female fertilization thereafter. So first, let's talk about what's going on. How is sperm made? So as you can see in the scrotum, you have your testes. And one of the main components of your testes is your seminiferous tubules, which you can think of it as a sperm factory. And you have different linings. You have your capillaries from the outside of each one of these tubules. And you have your Leydig cells. These Leydig cells produce testosterone. And that is a very important part of your development of male secondary sexual characteristics that we're going to talk about in a second. You also have your epithelial lining, all right? And what I want you guys to notice is how this is kind of like a concentric circle. You have, it almost works in phases. That's why we like to call it a factory. Where here you have your spermatogonia. They become your spermatocytes. They become your sperm. And then your sperm go through the ejaculatory here, your duct system. And then they're more developed thereafter. So it's kind of like, imagine like an arrow telling you, okay, this is the direction you should go in. Then you go out. So we talked about the two types of cells. Your Leydig cells that produce testosterone, that's very important for this whole process to happen. And you see these long cells here. These are Sertoli cells. So these actually provide nutrients to your developing sperm cells, all the way from your spermatogonia to your spermatocytes to your sperm. And they're also very important because they contribute to the blood-testes barrier. Now, why do we care about that? You guys might have heard of the blood-brain barrier that protects substances from entering your brain. The blood-testes barrier is just as important because these new cells that you're forming have new genetic material. They're not completely recognized by your body. They can be recognized as foreign. So if you don't have this proper barrier formed by the Sertoli cells, your body can actually start to attack itself and attack these sperms. And that can cause a lot of issues with things that we call like oligospermia, which is when you have a decreased sperm count, and other autoimmune diseases. So those are just the two key cells you guys need to keep in mind. You need to know that your Leydig cells are on the outside. They might ask you like in a histology-based question where each cells are. Your Leydig cells are on the outside with the capillaries. They produce testosterone. Inside, you have your Sertoli cells that provide nutrients to the new developing sperms and contribute to the blood-testes barrier. Right? So those are in our testes. And then we have the process of spermatogenesis. This starts in puberty. Same thing we talked about for female reproductive system, where before puberty, your GnRH, LH, FSH are low and continuous. So your pituitary doesn't really detect it as there's anything going on. But at puberty, these hormones intensify. Remember, they become pulsatile. They go up and down and up and down and up and down. And what happens then is you get secretion of your LH and your FSH. Your FSH, remember, in females, this would bind to our granulosa cells. Okay, here it binds to our Sertoli cells. So the reason I'm saying that now everything gets a bit easier is because you can kind of think of the male and female reproductive system as parallels. So the way our other cells work. So our FSH is going to stimulate the Sertoli cells to produce something called androgen binding protein. Why is this important? This causes more of the testosterone produced by LH to actually enter these cells and help with sperm production. You have your luteinizing hormone, or LH, binds to your Leydig cells. I just remember L for L, so LH for Leydig. And this leads to the production of testosterone. Okay, so this produces more testosterone, and then FSH binds to Sertoli cells. You get more ABP that lets this testosterone go in here and actually help the sperm develop. Okay, and so again, just to recap, at puberty, our GnRH secretion becomes pulsatile, so it goes up and down. And with that, you get more FSH and LH. Your LH, remember L for Leydig, so that binds to your Leydig cells, stimulates testosterone production. And then your FSH binds to your Sertoli cells, your nourishing cells, to produce ABP, or androgen binding protein. Okay, and this lets your testosterone actually go into the space to help the sperm develop. Okay, so this is again what happens with testosterone in puberty. You have your Leydig cells stimulated by your luteinizing hormone over here that leads to the production of testosterone. This happens because of an enzyme called 17-beta hydroxysteroid dehydrogenase. So this is again very similar to what happens in females, where you start with your cholesterol, you get to your androstenedione, but instead of using your aromatase enzyme to turn this into estradiol, you're instead using this enzyme to turn it into testosterone. But the initial steps are generally the same. This is just the only difference. All right. And just remember, your hormone production is all happening in your Leydig cells. It's not like your female reproductive system where, oh, you're producing it in the your theca cells and then it goes to your granulosa cells. No, everything is just happening in one place here. Okay, but the key difference is the enzyme that's doing it. Here it's your 17-beta hydroxysteroid dehydrogenase. All right. And so your Leydig cells are producing this testosterone. Why does this matter? So early on in life, testosterone, in pregnancy, testosterone is important for the formation of your general male sexual organs. So that, along with another hormone we're going to talk about later, tell me what kind of genitalia I'm going to have. And sometimes when it's abnormal, you're going to have different disorders of sexual development or different diseases that we're going to look at. But now we're talking about a normal person that is a 46XY male. What does testosterone do in this case after puberty? You have what we call primary sexual characteristics and secondary sexual characteristics. So primary sexual characteristics are associated with the genitalia and reproduction. So you have enlargement of the penis and testes and increased libido or sexual drive. And then you have your secondary sexual characteristics, which is what we usually associate with pregnancy. So a male pattern of hair, so facial hair turns from soft to coarse. There's a deepening of the voice, growth spurt, increased muscle mass, and erythropoiesis, which is increased formation of red blood cells. So in general, males have a greater amount of red blood cells than females. And this is one of the reasons because they have an increased level of testosterone in comparison. Okay, so these are just the different sexual characteristics. So now, after that, let's go back to the process of spermatogenesis. It usually takes around 2 months. And remember how we saw the organization of our seminiferous tubules? Everything goes inwards like an arrow. And so our spermatogonia are diploid. They're 46XY. Okay, obviously because this is a male. Then by mitosis, it's going to form a spermatogonium and our primary spermatocyte. The reason this is important is because you need continuous production of your spermatogonia to keep going back into the cycle again and again. Your primary spermatocyte, okay, then undergoes meiosis 1 to form our secondary spermatocytes. Okay, and now our secondary spermatocytes have 23 chromosomes. They undergo meiosis 2, all right, and then they form our here. So you have your spermatogonia, primary spermatocyte, secondary spermatocytes, and then that's going to form our sperm by a process we call spermiogenesis. And so the reason we're doing all of this is so we can go from our 46 chromosomes all the way down to our 23. These are our gametes. And we want to have one chromatid in each. Okay, so primary spermatocyte undergoes meiosis 1 to form our secondary spermatocytes that undergo meiosis 2 and then form our sperm by spermiogenesis. Okay, so this is just what you guys should know. They could ask you, for example, true or false, primary spermatocyte by meiosis 1 gives you secondary spermatocytes that have 23 chromosomes and 2 chromatids. That would be correct. But if I tell you they have 1 chromatid, then you know that would be after meiosis 2, for example. And I have a question about this to help clarify it for you guys a bit more. Okay, but this is just a general overview of this process. Once these sperm are formed here, they still need to go through the duct system in order to get further nourishment, in order to have further modification for them to actually be able to swim and function. Okay, and so remember we have 2 main cells that are supporting the sperm. The Leydig cells that produce testosterone, and you have your Sertoli cells, which produce androgen binding globulin or ABP, androgen binding protein, right? And so our Leydig cells produce a high level of testosterone, and that leads to negative feedback on the pituitary gland. What does that mean? That means if the pituitary gland sees that, hey, I have a lot of testosterone, I'm going to produce less LH. I need to kind of calm this process down. And the Sertoli cells produce inhibin. Remember, this is similar to our female reproductive system. Inhibin inhibits FSH production. Okay, so that way you're decreasing FSH and LH. And then this process repeats again and again. And so this leads to approximately the production of 100 million sperm per day, which you can see how large an amount that is in comparison to the female reproductive system. So just keep that in mind. These, differences are important for you guys in terms of exam questions and in terms of understanding the general processes that are going on. All right. So this is one of our first questions. Spermatogenesis is regulated by a negative feedback control system in which FSH stimulates the steps in sperm cell formation. Which negative feedback signal is associated with sperm cell production, inhibits pituitary formation of FSH? Perfect. Exactly. So remember, inhibin inhibits, okay? And it's produced by your Sertoli cells. This is what we just saw a second ago. So your Sertoli cells and your seminiferous tubules, they're the ones sitting in between the developing sperm. They provide nourishment, and they're part of the blood-testis barrier. They secrete inhibin proportional to the rate of the production of sperm cells. What does that mean? The more sperm cells I have producing, the more inhibin I give. When I release inhibin, it's going to decrease the amount of FSH. Okay? And so FSH binds the specific receptors on Sertoli cells, causing the cells to grow and secrete substances that stimulate sperm cell production. Okay? So the less inhibin I have, the less, let's say, nourishing fluid I'm producing in that case. All right? And so I could ask this question in this way, and they could also ask it in the opposite way. So which of the following is a characteristic of Sertoli cells in the seminiferous tubules of the testes? So again, similar kind of question, but what do you guys think the answer would be here? Yeah, perfect. Okay, So let's go through them one by one. So luteinizing hormone receptors, no, remember, luteinizing L for Leydig. So that actually binds to our Leydig cells, not our Sertoli cells. Meiotic division, no, they don't divide by meiosis. Those are our spermatocytes, but they're nourishing, right? Production of estriol, no, we mostly have the production of testosterone in the male reproductive system. So this is not the answer. Synthesis of testosterone, no, the Sertoli cells don't produce our testosterone, Leydig cells do. And so that's why this is the answer here. You can do it either by elimination or just by your knowledge that Sertoli cells secrete inhibin. Okay? Inhibin is going to decrease the production of FSH by negative feedback, like we saw in this picture here. Sertoli cells secrete inhibin to inhibit FSH. Leydig cells, the more testosterone they produce, that decreases our LH production. So this is just negative and positive feedback, or this is negative feedback in this case. Once it decreases, our FSH and LH are going to increase again and then start this whole process. Okay? Is that clear for everyone? Yep. Any questions so far? All clear? Okay, amazing. Okay, so next question regarding this. A pathologist evaluates the process of sperm production in the testes. It is noted that cells at different level of development are taken from the seminiferous tubules. Which of the following is true regarding spermatogenesis? A, primary spermatocytes have a haploid number of chromosomes. Spermatogonia undergo meiosis 1 in order to give rise to the primary spermatocyte. That's B. C, secondary spermatocytes undergo mitosis to give rise to spermatids. D, secondary spermatocytes undergo meiosis 2 in order to give rise to spermatids. Or E, secondary spermatocytes have a haploid number of chromosomes and one set of chromatids. What do you guys think is the answer? I'm going to give you a minute to think about this one. Okay. D, but is B wrong? دحين we're gonna talk about it all. This is that everyone's answer. Do you guys have anything else? Okay. Like I just need to. I'm so sorry. I'm just gonna stop sharing for 1 second because I have to fix. Okay. Done. Okay. All right. So our answer here is D. Secondary spermatocytes undergo meiosis 2 to give rise to spermatids. Like, let's, in order to better explain this question for you guys, let me just go back to the picture that we had earlier. Okay. So that you guys can understand okay, here we go. Like, so we have actually, no, there's a better picture somewhere. Yes, this one, perfect. So first we start out with our spermatogonia. Okay, these are our diploid cells. These are our 46XY, and they divide by mitosis. They're going to give us two types of cells. Our primary spermatocyte, which is also 46XY, or our spermatogonia, which basically just keep going into this process again and again. These primary spermatocytes are going to divide by meiosis 1 to give us secondary spermatocytes. So our secondary spermatocytes, remember meiosis, you're kind of cutting this in half. So you have your 23 chromosomes. So this is our haploid cells, our first set of haploid cells. Then these are going to divide by meiosis 2. secondary spermatocytes divide by meiosis II to give us our spermatids that have one chromatid. That's the important part. So this is by 23 chromosomes. They're going to be divided again. Now we're going to have our spermatids with one chromatid. Okay, and then these undergo a process called spermiogenesis, which is when they actually turn into full sperm with the acrosome and the tail and everything. Okay, so let's go back to the question here. So we know our secondary spermatocytes undergo meiosis II to give rise to spermatids, not mitosis. The only cells that undergo mitosis are going to be our spermatogonia in the very beginning, okay, that give rise to two. In this case, and later on, the further development. But this is the key concept here. So our spermatogonia undergo meiosis I to give rise to the primary spermatocyte. Here, let's go back. They don't undergo meiosis I, they undergo mitosis. So that's why this is not the answer here in terms of B. They don't undergo meiosis I, they undergo mitosis. Okay? Otherwise, secondary spermatocytes have a haploid number of chromosomes and one set of chromatids. No, they don't. Our spermatids have haploid number of chromosomes and one set of chromatids. Our secondary spermatocytes have two. Okay? So that's in general for the male reproductive system physiology. Do you guys have any questions or anything you want me to touch on specifically? All good, inshallah. Okay. That's perfect. With that being said, we're going to go into the last section for today, which is sexual development and differentiation. So first, let's take it back to pregnancy, when you're determining whether or not this baby is a male or a female. What is going on there? What is happening? So you have your fetal sexual differentiation. Now we know the main thing, males are 46XY, right? The Y chromosome is what makes a difference, whereas females are 46XX. And the reason this is important is because this Y chromosome carries your SRY gene. And without your SRY gene, that's what happens. You just turn into a female. So essentially, all undifferentiated gonads are females unless this SRY gene is present, and then we develop into males. So here you have your testes, for example. In your female, you have your ovaries. What does this SRY gene do, or what happens exactly? It leads to the production of two main hormones, your anti-Müllerian hormone and testosterone. So what I want to show you guys first is this. This is an undifferentiated female or male. We don't know at this stage. But you have two types of ducts. This is in the process of embryogenesis. So when everything is forming, you have this blue one, which is your Wolffian duct, which is present in males. Okay, so your Wolffian duct is present in males. Your Müllerian duct is present in females. So remember, we said the SRY gene is going to give us two things, anti-Müllerian hormone and testosterone. So anti-Müllerian hormone, anti means against, Müllerian is referring to this Müllerian duct, and it's a hormone. So that means when this hormone is produced, this is going to cancel out. You're not going to have any of the pink. Okay? Instead, your Wolffian ducts are going to remain, and then that's going to lead to the formation of your gonads, your male ducts, your seminal vesicle, your prostate, everything. Okay? And then you have your Müllerian duct in your female. What happens instead? If you don't have your anti-Müllerian hormone, you don't have your testosterone, what happens is this Müllerian duct is allowed to grow. Your Wolffian duct needs testosterone to continue developing. So if you don't have testosterone, it's going to regress or not develop. Okay. And then what you're left with is just as here, only your pink or only your Mullerian duct, and then that's going to develop into our female reproductive system. Our gonads with our, here this would be our fallopian tube with the fimbriae, the uterus, the vagina, everything. Okay? In terms of males, now, if you have your Mullerian inhibitory hormone or anti-Mullerian hormone, okay, then this is going to regress instead. The Mullerian duct is going to disappear. And instead, your Wolffian duct is going to proliferate because you have testosterone. So you need two things. You need this AMH and you need testosterone. All right? So that's what's important for us to know. Our sexual development is influenced by three steroid hormones. First, testosterone, okay? And this leads to the development of our internal male genitalia, except for the prostate, okay? So this is what we can see here. Our male internal genitalia, which is our, here you have everything in epididymis, you have your vas deferens, you have your seminal vesicle. So everything except the prostate, all right? You have your dihydrotestosterone, which is important for your external male genitalia and the growth of your prostate, also male pattern growth, and it helps to actually increase the levels of this testosterone. Okay, and then estrogen is important for endometrial proliferation and breast development and whatever. This is generally what we talk about later, but this is what's important for you guys to know. SRY gene, YXY is male. If you have a male that has anti-Mullerian hormone and testosterone, then that's going to lead to one, regression of the Mullerian duct. Two, it's going to lead to proliferation of the Wolffian ducts, and in dihydrotestosterone, development of the external male genitalia. So this is the general process or the general steps that we go through when in utero you're deciding, is this person a male? Is this person a female? Okay. And so let's say this case is a baby is born with a penis, a scrotum, and no testes, no vagina, and XX chromosome. This condition is referred to as hermaphroditism. What could cause this abnormality? Abnormally high levels of HCG production by the trophoblast cells. B, the presence of a testosterone secreting tumor in the mother's adrenal gland. C, abnormally high levels of LH in the maternal blood. Or D, abnormally low levels of testosterone in the maternal blood. Or E, abnormally low rates of estrogen production by the placenta. So essentially what we're looking at here is a female patient that has external male genitalia. What might cause external male genitalia to appear? Okay, I want to see everything you guys think, Heidi. We're here to learn. Okay, let's go through each of the answers together. The correct answer here is B, but let's talk about why. So we said the testosterone, right, and specifically dihydrotestosterone, is very important for external male sexual characteristics to develop. So if, per se, I have a female, right, XX, I have no SRY gene, meaning I have no anti-Mullerian hormone. Let's look at it this way, okay? I have no SRY gene, meaning I have no anti-Mullerian hormone. So my internal organs develop as a female. But I have a very high level of testosterone for some external reason. Maybe the mother is taking external testosterone. Maybe the mother, like in this case, has a tumor. Maybe there's another problem going on. But if I have these high levels of external androgens on a developing fetus, even if this is a female, then what's going to happen? I'm going to develop this external male genitalia. I'm not going to have the Wolffian duct proliferation and whatnot, but you can see that here. Okay, So a scrotum with no testes, no vagina, and XX chromosomes. So the reason this happens is because you have a lot of testosterone, okay, that causes this female to look like a male externally. Okay, so this is what we start to get into when we're talking about your external female virilization. So you can look at it as two ways. So you have something called hirsutism, which usually happens later. For example, patients with polycystic ovarian syndrome and high level of androgens because of that. That can lead to weight gain, acne, male pattern, balding, etc. And you have virilization, which is when you have someone who is genetically female that has features of deepened voice, for example, clitoromegaly, external male characteristics, because of these hormone levels. So here, the lack of a vagina and the presence of XX chromosomes, but also the lack of testes, basically, let me show you guys. There's a table for it later on, but what happens is the lack of AMH means the Mullerian duct does not regress, but it's not produced properly. Okay, so that's why you have an absence of the vagina, and you have lack of proper internal development of all of these organs. Okay, we're gonna go through more questions, but inshallah, it's gonna clear it up for you guys as well. Okay, so the main source of androgens. So you have testosterone, dihydrotestosterone, and androstenedione as well, produced by the adrenals. So remember, your testosterone is important for your differentiation of your internal genitalia, such as epididymis, vas deferens, seminal vesicles, except the prostate. And it's also responsible for the secondary sexual characteristics in males. Your dihydrotestosterone is important for your early differentiation of the penis, scrotum, prostate, okay? And other stuff as well. So let's talk about this. This is a similar theme, okay? So during embryological development, the gonads are bipotential, meaning they can either turn into a male or female. Which of the following hormones have to be released in order to have a male baby? So remember, there's two things that are important for us. And we have one that's important for the regression of the Mullerian duct, and the other that's important for internal and external male development. Yep, you guys are right. So the answer here is anti-Mullerian hormone and testosterone. AMH causes Mullerian duct regression. Testosterone causes proliferation of the Wolffian duct, and dihydrotestosterone causes external male genitalia. So remember, here's all the internal organs except the prostate. All right? Okay. Isn't D kind of true as well? Yes, but this is DHT is not going to be the determinant of whether you're a male or a female. Because like we saw in this case, this is a female patient, but they would have high levels of testosterone that is kind of also converted into DHT. So these two hormones alone do not determine that this baby is a male. Anti-Mullerian hormone and testosterone, those are the two key determinants of whether or not this child is going to be a male or a female, based on the presence of the SRY gene. Okay, no problem. Okay, so this is a bit of a long-winded question, but bear with me. I hope, through this, you guys are able to get the concept of what's going on exactly. So a 15-year-old female patient is concerned that she has not yet started her menstrual cycle. She is phenotypically female, meaning externally she looks like a female. She dresses, behaves, and has a psychosocial outlook of a normal, well-adjusted teenage girl. On physical examination, she has normal external genitalia, a blind-ended vagina, and no cervix. Okay. Imaging study reveals no uterus, but intrapelvic gonads, which on biopsy turn out to be testicular tissue. Karyotyping shows that this patient is 46XY. Which of the following is the most likely diagnosis? A, androgen insensitivity syndrome, B, female Kalman syndrome, C, female pseudohermaphroditism, D, Mullerian agenesis, E, true hermaphroditism, or F, Turner syndrome. Okay, the answer is A. Let's see why. So the features here on physical examination, the person looks like a female. Everything about them appears as female. The issue, however, is when we say she has normal female external genitalia, blind-ended vagina, no cervix, intrapelvic gonads. So this is interesting. So her internal genitalia appear to be male but underdeveloped. And this is confirmed by the biopsy that shows testicular tissue. The important thing here is that this patient is 46XY. So if I have a patient who looks completely female but is male, then I could have a couple of problems. One of the main ones is we said testosterone and dihydrotestosterone are very important for the production of our male reproductive organs, both internal and external, صح? So if this patient looks like a female but is a male, then maybe I have no problem producing testosterone, but my body is not responding to it. Okay, and so that's what's happening here. Androgen insensitivity syndrome is basically when the person's body is not responsive. There's a mutation on the receptor that binds testosterone that tells me, okay, let's develop external male genitalia. Let's fully develop my internal male organs as well. So this is complete androgen insensitivity syndrome. Is characterized by female body habitus and external genitalia, but with absence of internal Mullerian derivatives and cryptorchid testes, meaning she does not have, or this person does not have, a uterus, there is no cervix, the blind-ended vagina. These are all characteristic of male reproductive system. Intrapelvic gonads, but that have not descended. There are no testes because the body did not respond in order to produce these external male genitalia, okay? So that's this answer. What about the rest of them? I'm going to talk about Mullerian agenesis in a second. A blind-ended vagina, it's basically when there's no opening, if that makes sense. I have a picture in a second that with androgen insensitivity syndrome that hopefully is going to clear it up. Like, what is Kalman syndrome? Kalman syndrome is when you have the GnRH producing neurons are non-functional. So there's no GnRH. So it's what we call hypothalamic hypogonadic or hypogonadic hypogonadism, meaning that you have no production of the hormones in the beginning. If I had a question that had that, the person would for example, present with lack of menstruation or something. But once you administer an external hormone, meaning if I give them GnRH, they're going to develop normally, but they cannot produce it themselves. Okay, Mullerian agenesis we're going to talk about in a second. Turner syndrome. In Turner syndrome, the person is going to be 45XO. They actually lack a chromosome. So they are considered female, and that's associated with other things as well. And I have a table to explain this all to you guys in a second. But this is what I want to show you, in androgen insensitivity syndrome. So this person is a 46XY, so this is a male patient, but they have an androgen receptor defect, meaning they do not respond to testosterone at all. And so what happens to this testosterone, it's actually converted to estrogen in their body because high levels of testosterone can also be turned into estrogen. And that leads to breast development. However, we're going to talk about Tanner staging in a second. This person has no development of any pubic hair or similar characteristics, and no uterus and no ovaries. So if you were to examine it's like a closed loop. It does not lead anywhere. That's what they mean when they're saying it's a blind-ended vagina. It does not enter into the uterus or any other structures because there's nothing there in the first place. So there's no uterus, no ovaries. Why? Because this person had anti-Müllerian hormone, their XY. صح, the SRY gene is there. So they have their anti-Müllerian hormone. They have their testosterone. But the problem here is they don't respond to it. So that's why they get androgen insensitivity, okay? Exactly. So there's a vaginal opening, but it doesn't lead anywhere. Okay, because this person has external female genitalia, but not internal. Okay, you have cryptorchid testes, which means the testicles are there. They just have not descended anywhere because there's nowhere to descend to. Okay, there's no testes that developed, no axillary or pubic hair, and no penis or scrotum. So this person looks like a female, but is actually a male. Okay, in terms of their XY chromosomes, they just have testosterone that they're not responding to. And so this is androgen insensitivity syndrome that we just talked about. If I got you the same question, but the patient was 46XX, that means genetically this person is a female. Genetically, androgen insensitivity is a male. So this is a very key thing for you guys to differentiate in questions. In Müllerian agenesis, what happens is they have absent or hypoplastic Müllerian ducts, basically meaning they don't have internal female organs, okay? Or they have very underdeveloped female organs, okay? Because you have decreased development of the Müllerian ducts. But this happens in female patients. That's the key differentiating factor. Androgen insensitivity happens in male patients, okay? So just so you guys are aware, and this can happen in certain cases. And so if they get you a question describing one versus the other, they could present very similarly. But remember, 46XX means it's Müllerian agenesis, 46XY, meaning male but appears female, is going to be androgen insensitivity. Okay? And so what about the other causes that we were looking at in our differentials or in the question? You have Turner syndrome, which is 45XO, meaning they're missing an X chromosome. They get something called ovarian dysgenesis and streak gonads. So they have a lot of issues with their reproductive development. But the key thing they're going to get you guys in the question stem is the patient has a webbed neck, had issues with reproduction, or had, let's say, delayed menstruation, or the patient did not start their menstrual cycle. And you notice these features in your physical examination shows. So patient had a webbed neck, shield chest. They might describe widely shaped nipples, a issue with, for example, a murmur due to coarctation of the aorta. So all of these features are features of Turner syndrome. And the reason they don't have their period and don't develop properly is because of ovarian dysgenesis and streak gonads. So they literally get fibrosis in their ovaries, and then that leads to lack of ovulation and the whole menstrual cycle that we just talked about. You have Klinefelter syndrome, which is 47XXY. And this is basically going to be described as a tall, thin male patient that has low levels of testosterone, so they can have mixed features, testicular atrophy, gynecomastia, reduced facial and body hair. It's more obvious when you guys see it in the picture, but what's the key for you guys to know is the difference in the presentation here, like what is the underlying cause. For example, Turner syndrome is 45XO, Klinefelter is 47XXY. And you can also differentiate Klinefelter syndrome from something called double Y syndrome, which the difference here is double Y syndrome, you have normal gonadal function. Here you have decreased gonadal function. So in this case, you can have, severe acne because they can have very high levels of testosterone associated with ADHD and autism spectrum disorder. So just remember, they usually don't get the double Y syndrome in questions. What's more important for you guys to remember is Turner syndrome, Klinefelter syndrome, and they can get you androgen insensitivity as well. Okay. And so now I'm just going to do a quick review of puberty last time and some questions they can get you related to that. So again, all that we just talked about is you can be male or female depending on your sex chromosomes. If you are 46XY, you are going to be a male. Why? Because of two things. One, your anti-Müllerian hormone, which causes your Müllerian ducts to regress, and testosterone, which causes your Wolffian ducts to proliferate, okay? And dihydrotestosterone, which causes your internal and your external male genitalia to develop. So that becomes a male, a baby boy. If you have 46XX, then there's no anti-Müllerian hormone and no testosterone. So Wolffian duct regresses and this person develops as a female. Okay? And so once you have the sexual differentiation, all throughout childhood, the sex organs are going to mature until the patient reaches to puberty, when they would be capable of reproduction when the sex organs fully mature. So this is what I was trying to tell you guys about GnRH. Remember, in early life, in childhood, it's not really doing much. There's low continuous levels. What happens in puberty is you have something called a pulse generator in your hypothalamus. It's going to lead to a pulsatile secretion. So on and off, on and off, on and off, continuously. That's what leads to the production of our LH and our FSH. Okay. And over time, your LH kind of gets higher than your FSH. But this also differs for males versus females and at different phases, for example, in the menstrual cycle. And so puberty in females usually happens between ages 10 to 14, males a bit later, between ages 12 to 16. So this is what happens. Your GnRH pulses lead to LH and FSH. FSH stimulates Sertoli cells, which nourish our sperm, and our granulosa cells in females, which lead to the production of estrogen and progesterone. LH, remember L for Leydig, so that stimulates our Leydig cells to produce testosterone, and our theca cells to produce androstenedione that is then converted to estrogen by our aromatase in the granulosa cells. And so these lead to the production of our mature cells that lead to, in males, just the production of sperm, and in females, the menstrual cycle. And so the increase in sex hormones associated with puberty leads to the development of primary and secondary sexual characteristics. So the primary basically being the development of our genital organs and the growth of breast tissue in females. And so these two things are quantified by something called the Tanner scale. So the Tanner scale is measured based off of two things, pubic hair in both males and females, and testicular volume and penile length in males and breast development in females. So this is very important because the patients that we talked about previously, for example, with Müllerian agenesis, Turner syndrome, androgen insensitivity, Klinefelter, you'd be able to use this Tanner scale to see where they lie. Are these patients fully developed or are these patients minimally developed? And based off of that, you can kind of classify them into different categories. And so that's what's important for us to know about these. So this is stage 1 where you have no growth or no increase in testicular volume or penile width. There are no breast tissue in females, and you can see there's no hair on the external female genitalia. At stage 2, it's mainly characterized by an increase in testicular volume, not an increase in penile size, and minimal hair growth visible. And you can have the beginning of breast formation in females, but there are no breast mounds yet, and minimal hair that does not cover the entire mons pubis. Stage 3, you have also an increase in testicular volume and an increase in hair development. You have beginning of a formation of a breast bud in females and increased hair development. Stage 4, you have increase in penile width, increase in breast tissue development with protrusion in females, and increased hair as well. And stage 5 is what we consider someone to be fully sexually developed and mature in terms of length and a hair growth and breast mound, full formation of breasts in females. So this is important for you guys to know because it can help you classify the different patients that we talked about. That's 1. And 2, It's also important that they might ask you a question to determine the Tanner stage of a patient based off of the physical findings they give you. So that's what we're going to try to do now together, okay? So a 12-year-old boy is brought to the physician for evaluation. During evaluation of sexual development of the boy, his genitalia and pubic hair are at Tanner stage 2 of sexual development. Which of the following characteristics are to be expected or are expected to be seen at this stage of sexual development? A, the penis enlarges in width. B, coarse pubic hair appears and extends to the inner thighs. C, testicular enlargement. D, the penis enlarges in size and length. Or E, coarse pubic hair appears but does not extend to the inner thighs. Okay. Any other answers? Well, okay. You guys are correct. The answer is C. And so I added just a list of all of the stages for you guys so that you can refer back to it later. So in stage 1, this is what we consider pre-pubertal. So no pubic hair is present in males or females. Males have a small penis and testes. Females have a flat chest. That's what we saw in the pictures. Okay. Stage 2, you have soft pubic hair that begins to appear in both females and males, and the testes enlarge in size. So this is the important part in males, and the breast buds begin to appear, but you have no excessive growth or protrusion in females. Stage 3, the pubic hair begins coarsening. The penis starts to enlarge in both size and length now. And in females, breast mounds form and the breast enlarge. In stage 4, the pubic hair covers the pubic area. The penis widens and the breasts continue to enlarge and form a mound on mound contour. So that's important about stage 4. And stage 5 is what we consider full sexual development. So pubic hair extends to the inner thighs. The penis and testes reach adult size and the breasts reach adult contour. So this is full sexual development in both males and females. So important for you guys to keep in mind. I know it's more related to the endocrine lectures than the reproductive. One of the most common causes of early sexual development, let's call it, or abnormal sexual development, is congenital adrenal hyperplasia, specifically 21-alpha hydroxylase deficiency, which is an autosomal recessive condition. But for that reason, it's very, very important to examine your patients, especially newborns, before discharge, because if there are any increased levels of androgens being produced, because if you guys recall, the whole process of hormone production within the adrenal gland, if you have a blockage in the lower part of the pathway, what that's going to do is it's going to lead to increased formation of everything before that, including your androgens. So you can have very high level of androgens in a female patient with normal female internal organs. So that can be one of the causes, and it is one of the most common. And so it's important for you guys to know what are the differences between each. This is the last question I have for you guys. So please let me know if you have anything you're confused about. I can stay if you guys want me to re-explain anything. I hope this was helpful. And I hope you do amazing in your exam. And just please let me know. I'm of course going to share this PowerPoint with you as well. And there's explanation for each answer under the questions for the most part. Inshallah, ya Rab, you guys found this helpful. Please let me know if there's anything else you want me to repeat, anything you're confused about. Yeah, I'm here to help you guys as much as I can. Wallah, my pleasure. Allah yuwaffiqkum, ya Rab. Your exam is on Sunday, right? Inshallah, ya Rab. I hope it goes well. And don't stress. Make sure to know the differences between each condition, especially like the deficiencies. I know it can be a bit annoying. Menstrual cycle physiology, they really tend to ask about it a lot. That's why I tried to stress on it today. So try to revise, try to solve as many questions as you can. And inshallah, it's going to go well. I believe in you. And if you guys have any questions for me, please feel free to email me. and I'll try to get back to you as soon as possible because I know your exam is soon. Let me know if there's anything else you need. I am here. inshallah يوفقكم. And please let me know your feedback. If you guys could scan the QR code and tell me if you like the session, if my pace was good, if you'd like me to change anything in the future. You know, we do this for you guys to have the best experience at the end. That's what matters. 21 alpha or 21 beta. You guys can remember. صراحة, like I'm really tired. um it's congenital adrenal hyperplasia. المفروض I think it's 21. أهم شيء, remember the difference between 21, 17, 11, when you can have a salt wasting crisis or not. دحين أطلع لكم هي. I have, if you guys might find it helpful, خليني, I'm gonna share screen for one last thing. All right. Okay. I'm just gonna share my screen for one more thing. Because you guys might find it helpful. It can be a bit clinically advanced for your preference. Okay. Yeah. So basically, with regards to reproductive system and whatnot, I have just notes on everything. Again, this might be a bit much for you guys, but you can also find it helpful. It's basically as I've been going along throughout med school, especially solving for exams, for like UWorld, step one, anyone planning on taking step one soon, I kind of collect everything in one place. What specifically might be helpful for you guys is kind of as for example, like Tanner staging or sexual development. What I wanted to show you is, yeah, congenital adrenal hyperplasia. So this is important for you guys to know. See, حتى هنا they didn't even specify, they just said 21 hydroxylase. But the different presentations of something like this, like 21 hydroxylase deficiency, you're right, it's alpha now. Oh, no, I was right, it is alpha hydroxylase. Okay. So the defects that you guys might see along here. So if you have 21 hydroxylase deficiency, what I was basically trying to describe is you're going to have increased production all the way here. So this is going to be pushed towards producing more androstenedione and increased testosterone and estrogens. So you can have virilization early in life because of this. And yeah, and same thing applies for others like 11 beta hydroxylase. But this is just a very high yield topic for you guys to know for your exams. And they like to ask about it a lot. One thing that you guys should note in terms of 21 hydroxylase deficiency, because it is the most common, you're going to have virilization in female patients only, not male patients, because testosterone for them is normal. High levels of testosterone in a female patient lead to virilization. So just that's a small note, keep that in mind. But this kind of has everything in one place. You guys might find it helpful. I'm pretty sure I have the link somewhere. If not, you can just find it on my link tree, my Twitter. Yeah, precocious puberty. But yeah, that's it. If you guys don't have any more questions, I guess I'll leave you be. Allah يوفقكم يا رب. My pleasure. Allah يوفقكم. Okay, I'm gonna stop recording.